Yeah, no, sure. I don't think so. She would have told me.
All right, so welcome. We are on week 16. We roughly have 8 chapters left. Tonight we'll be covering chapter 20 and chapter 21, which is respiratory and cardiovascular. I'm going to hold off just a few minutes just because Carolyn should be joining us from Gray. I don't think it was this week.
I don't think so. Seems like she was sick.
Yeah. I know the other 2 online students already told me they weren't going to be joining tonight. So
if you miss a week, can you watch it online?
Yep.
So how do I do that?
They send me a message that says I need to watch it online and they send you the lecture.
Okay. So I'm on vacation next week. I might come to class, but I don't feel like it. I'm like, maybe I'll just watch it online.
That's fine.
I'm exhausted. I'm doing well.
Yeah.
All right.
Yeah, the lectures are available by just emailing me.
Okay. Thank you.
That's what most of the online students are doing that way. They're keeping up with us, or they're a little behind, but they're able to watch it at their own pace, start and stop it. That's the one thing I hear about it, is that they would love to be able to start and stop it when they need to.
Right. I can do that. I might just do that next week.
Yeah.
I didn't get through both chapters this week. This chapter is awful. I don't like it.
Respiratory is actually the easy one. Cardiovascular is the...
That's the one with cardiovascular. I just can't seem to even read it. Like, just...
Then just skim through it, do the quiz checks.
That's what I'm trying to do, but...
That's all you can do. You either love cardiovascular
I hate it.
or you hate it. There's no in between.
I was trying to think, there was one that I liked and I can't for life remember which one it was. Don't think it was respiratory. What was the test I just did? Maybe it was respiratory. The test I just did was hard, but... I think on that one, the one that I just had to reset for me, I think I was really nervous about the time. So I think I was trying to hurry the first time I did it because I was worried I wouldn't have enough time.
Hi there.
Hi, this is Fairfield. I don't know, the young ladies were here. I don't know if they're coming back in.
Okay, I don't either.
One of them, I had to ask you to do it anyway. For April.
I'm sorry.
One of the young ladies, Nikki.
Lily and Nikki.
Yeah, Nikki is not in the A class.
Okay.
Not April.
Okay.
I'm waiting for it to see if there's.
Very good. Thank you. I'm supposed to have one more site coming in. So go ahead and turn to your textbooks. Chapter 20 in Respiratory, 582. And in your CPT book, page 165. And you notice before that you have white space. And I told you if you have white space, make notes.
What page in 20?
Ladies left. Nikki, as I said, was not to be in class due to some financial stuff. The other one, I guess, decided that she's record this.
Okay,
I guess she's going to watch it from home. So you don't have anybody from Lawrence tonight, okay?
very good.
We'll log on.
All right, thank you. Carolyn.
Oh, there she is.
Hello.
Hey, Carolyn.
You have to turn on your microphone.
Oh, she always forgets.
Okay.
Thank you.
You can't read my lips?
What?
I couldn't read your lips, no.
Next week will be the last week that I will be coming to Gray because they're closing. So I'll be coming down to Westbrook.
Okay, very
Okay?
good. Yep. I think we can handle you.
Not too sure, you know.
All right, very good. All right. So we were waiting for you. We're on chapter 20 and 21. We are on week 16. We have 8 chapters left to go. As I was mentioning earlier, some people love cardiology or they hate it. There's no in between. I happen to be one of those that love it. I would actually like to even be able to go and code cardiology. Someone told me I was
Bless you.
crazy. Yes.
Not me.
Yeah. So maybe in my next lifetime.
You have 10 chapters left. Yeah, it helps if it was.
We're doing 20 and 21 today.
I know, you said we had 8 chapters left? Yeah.
Yeah. We don't usually do anything with 31.
With what?
31.
Oh, 30 and 31.
Okay, so you'll have to bear with me. My throat is dry and sore, so I might call on you guys a little bit more than usual. I'm going to start off with the respiratory system, page 582 in your textbook, and page 165 in your CPT book. Thank you.
Did you fall down, Carolyn?
She was making herself comfortable, kind of arranging her space. Okay, so as we've learned in earlier chapters, this section is divided by anatomic site. So you'll see in your CPT book we start with the nose. And then we move on to the larynx. As we discussed in last week's chapters, you also have further subdivision by procedure. So you'll see underneath the nose you have incision, excision, introduction, removal of foreign body, destruction, repair, other procedures. So throughout each anatomic site, you will have it further subdivided by all of those different procedures. So let's talk about endoscopy. Endoscopy actually is going to be in all subheadings except the nose. You'll see that it falls under accessory sinuses over on page 166. And it's underneath larynx on 169. And it's under trachea and bronchi on page 171. And you'll see that before each endoscopy, it's preceded by notes. So, the first rule in coding endoscopy is to code to the full extent. So, what I mean by that is the procedure begins at the mouth and it ends at the bronchial tube. The bronchial tube ends up being the full extent of that procedure. Okay? So far, so good? Rule number 2, code the correct approach. So for example, if I have a removal, I have an interior lung lesion that's done via endoscopy, and it's inserted through the mouth. Okay, again, approach. What's the approach? Exterior lung lesion via endoscopy, inserted through the skin. So interior endoscopy is through the mouth. Exterior endoscopy through the skin. So if you do an incorrect approach, you'll have an incorrect code, which means you'll have incorrect reimbursement. Rule number 3, surgery will always include diagnostic. So a diagnostic bronchial endoscopy begins, it identifies the foreign body, and then it removes. So that would be a surgical endoscopy, which includes the diagnostic.
It usually says diagnostic to surgery, right? Like it's like it flips. It starts at one and then of course
Right.
it goes to the other because maybe they removed
Right.
a piece or something.
Right.
Okay.
It might start out as a simple diagnostic
Right.
and turn into a surgery. Yes. So if we have multiple procedures, which you will see are frequent with respiratory coding, you want to watch for bundled services. With Medicare, you would reference your CCI edits. Now, with the software programs that we have today, your CCI edits are built right in, so we know what those CCI edits are. we know when we send it through to the clearinghouse, before it even goes to the payer, we've got an edit or a rejection or whatever. Always sequence the primary procedure first with no modifier. You would sequence any secondary procedures or procedures afterwards with a modifier 51. No different than we discovered in the other chapters. Bilateral procedures, we're talking about the nose. Bilateral procedures are often performed, so you would format the reporting for the payer. So Anthem might be okay with 31000 times 2. Cigna might want 31000 and 31000 modifier 50. This is where you have to know what the payers want. And it can be as simple as calling the insurance company and saying, how do you want this procedure? And we might be able to find it in their policy. That would be nice. Doesn't always happen.
How do we do it for the test?
It's going to be part of multiple choice. It's not going to say times 2, or it's just going to be part of the multiple choice. They're not going to do it in such a way that you would get it wrong because you chose one or the other.
Okay.
They're going to give it to you just that way, and you're going to decide which one is correct.
Okay.
So we can write this 4 different ways. Who can think of the 4th way?
You just, 31000, 31000. Oh, wait a minute, you already did that.
There's one more way we could do it.
31000 and 31000, right? Just the same code twice?
This is saying bilateral procedure. So you're doing it once, and it's indicating that you did both sides.
Mm-hmm.
Or you do it with the first one, and then you do it saying, or you do it times 2, or you do it right and left. So it's just knowing how does the payer want it. So if you see a multiple choice, you're going to only see one of these.
They won't ask you to choose it with or without the modifier?
It will be in there already.
Okay.
You will know by your code descriptor, am I supposed to have the modifier or not? Medicare, when you do Medicare, they just want to see the one line item. All right, laryngoscopic procedures. When you have these, you use the terms indirect and direct. It's real brief. Basically, indirect means using a tongue depressor with a mirror to view the larynx. And direct means the endoscopy is passed into the larynx where the physician directly views the vocal cords. So what page?
584.
Page 584.
169 is CPT.
Page 584 in your textbook. Laryngoscopic procedures using the term indirect and direct. Indirect means tongue depressor with mirror used to view the larynx. And direct means endoscopy is passed into the larynx where the physician directly views the vocal cords. And what'd you say, 184?
I said 169.
169 in the CPT book. So that is something that you would want to highlight or underline, direct or indirect. With biopsy, with removal.
What was the indirect again? It was,
Tongue depressor.
Okay.
All right, so we have the nose. We're still on page 165 in our CPT book, page 584 in our textbook. The nose, 30000 through 30999. You will see that these codes are used extensively by your otolaryngologists, which are your ear, nose, and throat specialists, or also known as ENT. ENT. You will also find that these codes are used by a wide variety of physicians. So, when it talks about the nose, we want to consider what approach. Is it the external approach? Because if it's the external approach, we're going to use integumentary codes. So make a note up here next to nose, external approach, use integumentary codes. Right next to nose, external approach, use integumentary codes.
I'm just looking because I know I wrote that down.
And then next to respiratory system, you can write internal approach. All right, incision underneath nose. You're going to see bundled into the incision codes are your drain or gauze insertion and removal. So under incision, we only have two codes there. You're going to see that bundled into these codes, you have the drain or gauze insertion and removal.
Did you say excision or incision?
Incision. Nose incision.
And bundled is what?
Your drain or gauze insertion and removal. So in those codes, you have drainage abscess or hematoma, drainage abscess or hematoma, and one is nasal internal approach, one is nasal septum. And pay attention to your parenthetical notes. So right there, these codes include what we have bundled in it are the drain or gauze insertion and removal. Keep in mind, any supplies are going to be reported separately. Okay?
Really? Like what?
Supplies would be reported separately.
Okay. Wouldn't your drain and your gauze be supplies, or you're gonna?
Any other type of supplies. Then we have nose excision, 30100 and 30160. These actually contain the intranasal biopsy codes. So if you have a polyp excision, you're going to pay attention to the complexity. Your polyp excisions are by complexity. Simple involves polyps that are easy to remove. So pay attention here to what is the complexity. Is it simple? Is it extensive? Your extensive involves sessile polyps, which means it has a thick base. And I believe you have a picture of it in your book somewhere, on page 586, I believe.
What are those polyps named? The extensive?
Sessile polyps.
Sessile.
And the reason why they're extensive is because they're more time consuming and they require greater skill. So with that, you would look at code 30115. 30115 involves more time and requires greater skill. Excision includes any method of destruction, even laser. So excision, any method of destruction, even laser. So again, what is the complexity? Is it simple? Is it extensive? Is it laser? Is it partial? Is it complete? Those are the key words to highlight that should jump out at you. And if you do a bilateral, you can use modifier 50. The 30140 is a reduction of the turbinates. So it says right there, resection inferior turbinate, partial or complete, any method. You can write beside that reduction. Resection, reduction.
Beside which code?
30140. And if you look at figure 20-4, you'll see a picture of the nasal turbinates. Excision of the turbinates are actually considered unilateral. So again, if they're performed bilaterally, use a modifier 50. Over to the next column under introduction, nose introduction, 30200, 30220. These are common procedures. This is where they might put injection to shrink the nasal turbinate tissue. Okay? There might have displacement therapy, which is a saline flush that's performed through the nose to remove any mucus. And you might even have an insertion of a nasal button. And they put right next to the code for you in parentheses button, 30220. They put it in parentheses button.
And you can find that in the back of the book under button.
Yep.
It's not under insertion.
Well, it's a prosthesis.
Yeah, well, I couldn't.
All right, removal of foreign body. You have 3 codes there. This is divided by whether the removal is at the office or at the hospital. And it just requires general anesthesia. Nose repair, 30400 through 30630. Underneath nose repair, there are a lot of, quite a few plastic surgery procedures, such as rhinoplasty. When we hear plasty, we are reshaping, and it's either internal or external. When it is stated as revision or primary, take a look at your code, see if anything says revision or primary. Those you want to highlight. So is this a primary procedure or is this a revision of a procedure? You also have rhinoplasty for nasal deformity. That it happens to be secondary to congenital cleft lip and palate. And then you have the septoplasty, which is the rearrangement of the nasal septum, which you will find is included in a rhinoplasty.
Nasal septum.
You said. There was a question in the workbook on that, and it says, it doesn't say osteomostes, motes. What is osteo? That's bone, right? Cut into the bone. Okay, that's just the whatever in there.
You said the septoplasty was included in one,
The rhinoplasty.
so you wouldn't bill both?
No.
So if they do a rhinoplasty with a septoplasty, you just code the rhinoplasty.
Mm-hmm. Nasal reconstruction. Okay, the nasal reconstruction, you have codes for obtaining grafts for reconstruction. Actually, you're going to find these in the musculoskeletal subsection or the musculoskeletal system subsection. So when you talk or hear nasal reconstruction, it will be musculoskeletal section.
So my daughter had a damaged septum, and he just went in and repaired that. So if I would have, and she has that bump on her nose thing, and she wanted to get it fixed, and that's really cosmetic, so it would have really charged me. So I could have had that all in one, and they would have billed it under the rhinoplasty. Oh, that poor deprived kid, though. It would have been cosmetic.
Yep. So you might also find that some codes for other procedures might fall underneath your integumentary section. So it's just knowing what they're doing, okay?
The approach, right?
Right. Is it the external approach? If it's the external approach, you're going to find it in the integumentary system. And you wrote that already at the beginning of your section. All right, nose and destruction on page 166. When we use ablation, what is ablation? You remember, Celeste? What's the use of ablation?
I can't remember. I'm sorry.
It's okay. You saved my voice for 30 seconds. Removing by cutting. Also, destruction is used for the removal of excess nasal mucosa or to reduce any turbinate inflammation. It's all based on, is it intramural or superficial extent of destruction? Intramural is the deeper mucosa. Superficial is the outer layer of the mucosa. And you can see on page 588, they have some good shots there of different things they do.
I don't understand the difference between anterior and posterior nasal cavity.
Isn't it the balloon?
Yes,
That's for nosebleeds, right?
yes.
So anterior, you put it up here. Posterior, what, swallow it with the, oh, they make it and they put it in your mouth
They go up and pack it.
with an incision or
No, they just go up and into the nasal cavity
from your mouth?
from your mouth.
They put you to sleep first, right?
Yeah.
They'd have to.
Yeah. So, when we talk about nasal hemorrhage, the codes are 30901 through 30906. These codes are going to be based on the site of the hemorrhage and if the control was simple or complex. So if a posterior hemorrhage, you want to know, is it the initial or subsequent procedure? Excuse me.
What was that again? I'm sorry.
The codes for hemorrhage are based on the site and was it simple or complex to control? And if it is a posterior hemorrhage, is it the initial or the subsequent procedure?
If it's a posterior. Okay.
Are they gonna tell you that?
Yes.
So simple, complex, initial, subsequent.
Now under nose and other procedures, 30901 through 30999, we want to know about the control of the nasal hemorrhage. What are they using? Are they packing? Are they doing ligation or cauterization? The anterior packing is placed through the nose. The posterior packing is placed at the very back of the throat. So, to code a nasopharyngoscopy with an endoscope, you would code it from the medicines, which is 92511. It is pretty much bundled into any respiratory procedure that is performed at the same session. So if you look under here, under other procedures, 30901 through 30999, it's safe to write that 92511 may become part of this session. 92511 is a nasopharyngoscopy with endoscope. It's going to be bundled into any of your respiratory procedures that are performed at the same session.
So, how do I write it so I'll know what it means?
92511 is bundled into respiratory procedure performed at the same session. Again, on 588, it shows you a couple different, 588 in your textbook, it shows you couple different ways how they pack the sinuses. The sinus accessories or accessory sinuses on page 166 in your CPT book. This would include your incision, excision, and endoscopy. These codes are 31000 through 31299. You're going to find the codes for a lavage of the sinuses. A lavage is a washing. They use a cannula, which is a hollow tube. It's placed into the sinus, and then saline solution is flushed through. You use a modifier 50 for bilateral for both sides. A sinusectomy is where all sinus contents, including the mucous membranes, are removed. And an antrostomy is making an opening into the sinus. And antrotomy means cutting into the sinus. So we have an antrostomy, S-T-O-M-Y, making an opening into the sinus. And antrotomy means cutting into the sinus. And you see right in your parenthetical notes, it tells you to report bilateral procedure, use a code with the 50 modifier. Okay? It tells you sinusotomy, intranasal sinusotomy, ethmoidectomy, maxillectomy, all right there on 166 and 167 in your CPT book.
'Antrostomy. Where are you seeing the antrostomy?
Antrostomy is on page 168. The first one I see is, I just lost it, 31240 in the parenthetical note. All right.
Can you tell me one more time, I'm sorry, what antrostomy is?
Making an opening into the sinus.
Thank you.
Mm-hmm. (31240), you should see antrostomy, Lori. You see it there?
Yeah.
In the parenthetical note? Okay. So antrostomy is making an opening, antrotomy is cutting an opening. Making an opening, cutting an opening.
So they make it a different way? They don't
Yeah.
cut it? So like, as in, how else would you make an opening? Needle?
All right, larynx, 169, top of 169 in your CPT book. Excision of the larynx, 31300 through 31420. A laryngotomy is an open surgical procedure to expose the larynx. They might do this to remove a tumor. Do not confuse this with a trache and bronchi code for tracheostomy. A laryngotomy is not a tracheostomy. A tracheostomy is used to establish airflow. So, right on code 31502, tracheostomy tube change. Tracheostomy, establish airflow. A laryngoscopy is a visual exam of the larynx. This is where a flexible lighted tube is passing through the mouth or nose into the larynx. So laryngoscopy, visual exam of the larynx. Introduction of the larynx, 31500 and 31502. We just talked about this. Endotracheal intubation is an establishment of the airway. Intubation and endotracheal intubation involves a tube being placed through the nose or the mouth, through the pharynx and the larynx, and into the trachea to establish an airway. So intubation is through the nose or the mouth. A tracheostomy, they just make an opening right there in your throat. Larynx repair, over on page 170. You will have several plastic procedures and fracture repairs with this code. A laryngoplasty, plasty means what?
Repair.
Repair. It's also, the procedures will be based on the purpose, so what are they doing? A trachea and bronchi incision are codes 31600 through 31614. Most of your codes under the trachea and bronchi incision are going to be for tracheostomy. You will see that it is either a planned or an emergency. So highlight planned or emergency. What type? So it's divided by type. Is it transtracheal or cricothyroid?
What were those codes? 31615?
31600
Okay.
through 31614. It is the trachea and bronchi on page 171. So these are going to be most of your tracheostomy codes. Was it a planned one or was it an emergency one? And then divided by type, transtracheal or cricothyroid. Then we have the transtracheal approach and the entry, and you'll see on figures 20-12 and 20-13 on underneath trachea and bronchi in your textbook. They show you the different approaches. In 2014 and 2015, show you the cricothyroid approach and entry. Page 592 in your textbook. So Lori, whatever 20-14 and 20-15 is for your figure, probably ahead, not back.
Sorry, I've been following you.
That's fine. Nope, that's fine. You've already seen the pictures right there. Yep. Yeah, you have the right pictures. All right, endoscopy codes, 31615 through 31661. The bronchoscope is inserted into the nose or the mouth. It's a rigid endoscopy that is usually performed under general anesthesia. A flexible endoscopy is performed under local or conscious sedation. Your trachea and bronchi introduction. Codes 31717 through 31730 on page 173 in your CPT book. you'll see for these few codes, you have a catheterization with a bronchial brush biopsy, and then you have an aspiration for airway clearance, and a nasotracheal catheter, and a tracheal bronchial fibroscope. And if you look at 31725, that's done with conscious sedation. Trachea and bronchi excision repair, 31750 through 31830. This is your plastic repair of the trachea and bronchi. So code 31750 through 31830. This is your plastic repairs of the trachea and bronchi. This is where you'll see the excision of the stenosis and the tumors, suturing of any tracheal wounds, any type of scar revision.
Can you tell me, like, 31770, I read it says bronchioplasty graft repair.
Yep.
And then it says grafting procedure repairs reported separately.
Yep.
So it would say, it could say tracheal, pharyngeal, fistular, each stage. And could they have a plasty and they may code this? It's not going to be in with the regular. Okay.
That's a good question, because
Is that like a flap graft?
well, a bronchoplasty graft repair, they're taking the graft from somewhere else.
Does that mean they're repairing a graft that's already there, or they're using a
They're
graft
repairing
to
a
repair?
graft.
They're repairing one that's already there.
Yeah. Because with the tracheopharyngeal fistula, I don't see how they would use the graft repair with that. It would just depend on the notes and query the doctor. This is where we start thinking too much and we get ourselves in trouble. What if? What if? What if?
Well, that would be something right here.
Yes.
You're trying to
Yes.
fix.
Yes. Yeah.
Okay.
So lungs and pleura, incision and excision. You see the big long note before you even get to any of the codes. All right, this is where you have biopsy codes that are already in the incision and excision categories. So your excisional biopsy with a percutaneous needle, your incisional biopsy with chest open. So again, read the note before. The incision and excision codes also includes the pneumocentesis and the lung removal. Yeah, right in the notes, this is what you want to be looking at. The lungs and the pleura. Pleural cavity or lung biopsy procedures may be accomplished using a percutaneous thoracoscopic VATS or thoracotomy approach. So right there, they're telling you in the notes what type of approaches they might have. They involve the removal of differing amounts of tissue for diagnosis. A biopsy may be performed using different techniques such as incision or wedge. So Lori, right on page 173 right here in the notes. Yeah, right there. So a biopsy, so right there, techniques such as incision or wedge. Lung resection procedures include diagnostic and therapeutic. including the removal of blebs, bulla, cysts, and benign or malignant tumors or lesions. So just read your notes there. Then at the bottom, that paragraph at the bottom, it talks about more extensive anatomic lung resection procedures at the last sentence, which can be performed with either thoracotomy or thoracoscopic approaches. So again, knowing your approach, knowing the segment, is it an incision, is it a wedge? Is it unilateral? So remembering that it includes the pneumocentesis and the lung removal. If we're doing a segmentectomy, it's going to be only one segment. And if we're doing a lobectomy, it's one lobe. And if we're doing a bilobectomy, it's two lobes. So over on page 175 in your CPT book, 32480 is a lobectomy. 32482 is a bilobectomy. And then 32484 is a single segment. Okay, page 175, 32480, 32482, and 32484. Page 175, 32480, 32482, and 32484.
Thank you.
So one lobe, lobectomy, bilobectomy, and single segment. And then if we do a total pneumonectomy, that's one lung. So removal of lung 32440. 32440. Total pneumonectomy, one lung. And Celeste, you can give that to Nancy after. Thank you. All right. Lungs and pleura incision. (32035) through 32225. Again, lungs and pleura incision, 32035 through 32225. This is a thoracotomy. This is a surgical opening of the chest to expose it so you can view it. What do we want to view it for? We want to view it for biopsy, for a cyst, for foreign body removal, and for cardiac massage. So those are the things that we want to highlight in any of those codes that are between 32035 and 32225. We want to highlight, is it a biopsy? Is it a cyst? Is it a foreign body removal or a cardiac massage?
You open the chest to view. That's why you would do this incision, and you're going to view possibly for a biopsy or a cyst.
What was the other thing, Laurie? Is it biopsy, cyst, and what else could they be looking at?
Cardiac massage.
Cardiac massage.
Okay. 321.
So what, okay, open chest to view,
Yeah.
biopsy, cyst,
Cyst
or-
and cardiac massage, she said.
And
found
the
it when they asked.
32035 to the 32225 is what notes?
Is
Oh, they open the chest up. That's why they would do a thoracostomy to open the ribs up. You open the chest. It's kind of they crack the chest. scanner probably, just like they do the heart, and they open, they view, because they want to do an autopsy, look for a cyst in there, or cardiac massage. And that's why they would use like those incisional codes, like 32035, 32036, and 32096. What did you say? What were you saying?
Oh, no, I just found that if the wording was in the text, what they asked for, if we had the wording, it was easy enough to find in there as long as they were clear in here.
Yeah.
Which are probably never going to be with the real knowledge.
Well, yeah. Yeah, sometimes.
You're not gonna code this unless you code for
Yeah, for a
Yeah.
respiratory,
most of the time.
yeah.
Okay. Excision. Codes 32310 through 32405. You're going to see biopsy codes in the excision and incision categories. The excisional biopsy is usually performed with a percutaneous needle. The incisional biopsy performed is when the chest is open. So those are the things: percutaneous needle, incisional biopsy, open chest.
Three two four oh five says moderate sedation. That means you're awake for that?
Yeah.
How awake are you if I'm just moderate sedation?
Enough so that you're able to understand what they're asking you to do.
It's like, again, like a, when you're going to have the, be checked for colon cancer, what is it, colonoscopy. It's moderate sedation, right?
Yeah.
I don't remember anything when I had it done. I remember nothing. So they could have asked me questions and I probably could have answered them right, but
Yeah.
you don't really remember it. It's almost like just kind of erases your memory.
It's enough to relax you so that you can respond to commands, but you
don't really know what's going on.
Right.
Is
It's
this,
kind of wonderful.
it's a good nap.
Yeah.
Is this the spreader they talk about, is that the same spreader they use to kind of crack your chest to go into the heart? It's pretty much the same. Okay.
So the excision and resection, I only see the percutaneous needle. So is this not opening you up? It's just needle?
just that needle. Yeah.
Okay.
Do they have maybe like a film, so they're looking over here before they kind of
Yeah.
go in and just do
They're gonna
it?
do it with
Image guide.
Like,
image
yeah,
guidance.
okay.
All right, lungs and pleural removal. Codes 32554 through 32557. So 32554, 32557. So we're jumping over a few pages. On page 176 in your CPT book, a thoracentesis is needle or catheter that is inserted into pleural space for aspiration, which is withdrawal of fluid or air for analysis, and to drain the pleural effusions or to re-expand a collapsed lung.
So the thoracentesis is to drain
Drain fluid
fluid, right?
or re-expand lungs. Okay, so the removal, lungs and pleural removal, 32556 and 32557. This is where the chest tube might be inserted to drain fluid, or a really long syringe may be used to aspirate any fluid in there. The introduction codes 32550 and 32551 on page 176, 32550 and 32551. These include moderate sedation. This is where there's insertion of a tunneled indwelling pleural catheter. It's a tube thoracostomy. Again, it includes the moderate sedation. Your removal code is 32552, and your destruction is 32560 through 32562. Your destruction codes are chemical fluoridesis or effusion.
32552 and 32.
32552 is
Oh,
removal.
Okay. Oh, I see them right down there. Okay.
32560 through 32562 is the chemical fluoridesis or effusion. They use this for recurrent persistent pneumothorax or multiloculated effusion.
You say.
Just recurrent persistent pneumonia. All right, your thoracoscopy, 32601 to 32701, page 177. This is your diagnostic and surgical lung procedures. Your surgical thoracoscopy always includes the diagnostic. Pay attention to code 32701. This reports the stereotactic radiation therapy.
What is that? What is that? Stereotactic radiation therapy? I don't know.
It's radiation.
Just radiation of the lung?
Yeah. It targets where they want the therapy to go. And it's going to be done between a surgeon and a radiation oncologist.
Oh, have you ever tried Brittany called taking medicine, the Dilatin, crushing it up and putting it is in there for collapsed lung. I just didn't
All right, turn to the end of your chapter for chapter review, theory and practical. Did everyone do those? Yes, no, maybe?
I did.
did.
I did this one, not the next
I
one.
couldn't get to the
Okay, so we'll go over this one and I'll send you the next one, chapter answers in the email.
Did you send us the other one?
I did.
You did?
You did?
I don't know if I saw it.
I think I saw it,
I
yeah.
didn't see it.
I was actually good that night and got them out the next time.
Oh.
I'll have to look again.
I'll resend them.
Like, you need more work.
All right, so review, number 1, anatomic. So we're on page 597, chapter 20, chapter review, number 1, anatomic. Number 2, endoscopic procedure or endoscopy. Number 3, extent. Number 4, modifier 51. Number 5, diagnostic. Number 6, indirect. Number 7, direct. Number 8, ear, nose, throat. Number 9, integumentary. 10, respiratory. 11, inferior, middle, and superior. And 12, displacement.
12.
Displacement.
Banana therapy physician flushes saline solution.
To remove mucus or pus.
Is that
Displacement.
lavage?
No, that's your ears.
What's the lavage?
Lavage is your sinuses in your ears. All right, 13. 32997. 508.2. 14. 32310 and 511.1.
What was 14?
32310, 511.1. 15.
Oh, I thought we were only supposed to do ears. Oh, I guess that's in the other book, isn't it?
Yeah, that's fine.
That's okay.
15, 32504 with 197.0. 16, 30300 with 932. 17, 31237 with an RT modifier and 471.0.
What number are you on? 17?
17,
That was 17.
What did you have for the CPT?
31237 with an RT modifier.
I marked the wrong one. Getting ahead of myself here.
18, 31530 with 933.1. 19, 31510 with 478.79. 20, 30000 with 920. 21, 31070 with an LT modifier and 473.1. 22, 31287 with 461.33. I'm sorry, 461.3. Sorry. 23, 30520 with 738.0. 24, 31625, 32480 with 162.3.
Doreen,
Yes.
what were those again? 24, those CPT codes?
31625 and 32480.
Oh, I had them reversed. Okay.
25, 31255 with an RT modifier and 473.2. with 471.9. '26, 30901 with 784.7 and 401.1.
On 25, you had 473.2, and what was the other number?
471.9. Yes.
I was just wondering if I could ask what the ICD-9 codes were for 15.
Yep. 197.0, 199.1. All right, we'll take a quick 5 minutes and come back and finish up 21.
Are we gonna go over the chapter, over this part of 20?
In the workbook, yeah.
Probably in 15 minutes. Okay, got it.
Is it okay to ask you a question?
Sure.
In chapter homework in 20,
Yep.
on exercise 21, number 5,
Mm-hmm.
it said segmental resection of the right single lobe using a flexible endoscope, surgical thoracoscopy. Yeah, I'm not very good at these words.
Yep, that's fine.
So the CPT code 32663, and I said, how come the answer does not include RT here, but includes LT on example 23, number 2?
Which one?
Because I checked them in the back after I do them.
Let's look at this code.
Sorry, what was it?
32663. Because right here they're telling you it's a single lobe. And here they're telling you
Rita.
that it's right. So
Yeah,
this
text
doesn't
from her,
indicate
said,
right
call
up
me in
that,
15 minutes.
because they used it in the description. Because
I called her,
RT
she's
or
like,
LT.
didn't you text me? I said, no, I didn't text you.
What was your question? Was that a question?
Surgical rate raising cap endoscopy.
If you didn't put it, it's not wrong. I wouldn't mark it wrong.
Okay. How did she get that? Did you get this? Well, I think
Which
it
one
was,
number?
it was number 17. Is it?
No, because I went to.
Oh, you did the odd ones again. I don't know how she got that number. Did you get for 17? Did you get 30? I scribbled it in. So
17,
30220. What'd she get?
surgical right nasal cavity.
Yeah. Is that the
31237.
Oh. Okay. 31237. Okay. I'm trying to
So
figure
either
out what I
one,
did wrong.
because they indicated it in the exercise, we would put LT or RT. I wouldn't have marked that wrong. I think here they're just simply
Okay, I
looking
see
for the
that.
code.
I see that.
Did it have the RT in the back?
Removing an endoscope.
And there's
I think
also
so.
one she gave us.
I wouldn't mark it wrong, but when you see
It's
this,
a what?
if
It
you
doesn't
never
seem
see
like
it
the right
in
answer,
code,
number 20.
make
She
sure you
said,
put it on here.
but
If
it's,
I
she
don't
did
see it in
302
the code,
because
and
it's.
it says
That's what
right
I got
in the
too.
question,
And
make sure I
so
put
that's right.
RT.
So I did it right.
Correct, because
Or
Yeah, I'm
RT,
not gonna
sorry.
correct too.
Because it only says
they have enough trouble getting
unassigned.
I thought that was
Front
true,
door.
Is there a book that's got a wrong
Okay.
answer? Or
Because
Yeah,
this is
yeah.
indicating
Reason.
left.
Yes.
So.
I didn't see what I
you
got
wouldn't
wrong.
notice it right away.
What's that?
I don't do
Okay.
Okay, they just don't tell you that there. They don't say.
Your mind is not here.
Okay,
So if you
It
see
is,
it
it's
here,
on summer
pretty
and
safe to
I
say
know
use
it's
that.
hard.
okay,
Okay.
yep, thank you.
Number 23, Doreen. Now, I guess I could get that out of that. Okay, it says submucosal resection of the nose with scoring of the cartilage and contouring. I guess I would get resection, repair. Okay. Now I got it. Okay.
All right, give me just a second to make this lower. All right, chapter 21, cardiovascular system. Going to be in page 601 in our textbook.
Are we gonna do this?
Oh, sorry. Yes. Let's go back to our workbook for page 20 first. Our workbook for chapter 20 first.
20. Not 20.
Chapter 20. Workbook chapter 20.
Yep. You said 21st.
Yes. Page 123. One is D, 2H, 3K, 4O, 5B, 6N, 7C, 8G, 9F, 10P, 11M, 12I, 13A, 14L, 15E, 16J. 17, nasal button. 19, rhinoplasty. 20, septoplasty. 20, ablation.
Wait a minute, 19 was,
Septoplasty.
and 18 was what?
Rhinoplasty.
Okay, oh my God, I'm sorry. Okay.
21, posterior
What was 20?
ablation.
Okay.
22, lavage. 23, transtracheal and cricothyroid. 24, no, the procedures are bundled.
Can I just ask a question?
Sure.
I said no, a chest tube is part of the procedure?
Yep, that's fine. 25 is modifier 50. 26 is bilobectomy. 27, 31267. 28, 31511. 29, 31628 with an RT modifier. 31632 with an RT modifier.
Should they be in that order?
Yes. 30 is 31623. 31, 31575. 32, 30100. 33, 30801. 34, 30400. 35, 30115 and 30115 modifier 50. 36, 30220. 37, 31536. 38, 31611. 39, 31400. 40, 31579.
3147.
31579. 41, 31720. 42, 31750, 43, 31830, 44, 32554, 45, 32658, 46, 32854, 47, 32800, 48, 32815, 49, 30930, 50, 31050, with diagnosis 461.3, 51, 31613, with 519.01 and 682.1.
Can you repeat that again? I'm sorry.
31613
Okay.
with 519.01 and 682.1. 52, 31625 with 786.2. 53, 32440 with 501. 54, 32604 with 393. 55, 32900 with 756.3. 56, 31766 with 162.2. 57, 32560 with 183.0 and 511.81. 58, 30125 with 229.8.
9 on 58?
229.8.
Can we do the reports together?
Yep.
I didn't do them. Did anybody else do them?
I didn't,
You did?
on this chapter.
I didn't do them. I couldn't.
I'm having a hard time with reports.
Yeah, me too.
Yep. That's not unusual. Okay. So choose number 60, report number 21. Carolyn, did you do these?
No.
Okay, we're going to do it together in class. All right, so page 222 is report 21. The preoperative is atelectasis of the right lower lobe, suspecting either a mucus plug or obstructing cancer. The postoperative diagnosis, mildly inflamed airways with some thick secretions. No definite mucus plug was seen, and certainly no cancer was noted. Then they go on to tell you a bronchoalveolar lavage, bronchial brushings, and bronchial washings. Now, with what we just read over in the chapter, is the brushings and washings included in the lavage? So where would we start? What was the diagnosis?
Collapsed lung, right?
They found something. They weren't sure if it was cancer or a mucus plug. So but the procedure performed, because we're doing the procedure performed first, that would be a lavage of the lung. So start with that. Go to lung.
So you wouldn't go to lavage?
You can try that too. And then once you find lung, what does it give you?
Says the bronchial and total.
Okay, so they told us they did the bronchial brushing. So what did they give you for a code?
31624.
Okay.
With bronchial alveolar lavage.
Okay, it says there, you put the bronchoscope down the endotracheal tube. So is that not a bronchoscopy? Because I have 31622 as the first code.
No.
So is it?
Well, because they specifically tell you bronchoalveolar lavage, and you have a bronchial alveolar lavage procedure, you would use that one first.
Okay. So you ignore the bronchoscopy.
Yes. So the 31624 is your first code.
What? How come not 31623? Because it says bronchial
have that too.
brushings.
Because bronchial brushings was done after. They started going in the lavage. Remember, the first procedure, the bronchoalveolar lavage, that was first.
Okay.
Then the brushing, and then the washings.
So
The brushing and the washing actually will be together. It's with brushed and protected brushings.
What do you mean together? You mean you
The
call
31624 is first, and then the 31623 is next.
Okay.
As the 51 modifier.
oh,
Because in the middle of the paragraph, they tell you that it did take a little suctioning to dislodge all of the mucus. However, it was not as bad as I thought it would be looking at the x-ray. The area was brushed, washed, and then, to be more specific, because of evidence on a chest x-ray of something going on in the periphery, a bronchoalveolar lavage of the right lower lobe is performed. The patient tolerated the procedure well. So the lavage is going to be first because that's the more extensive.
Okay, and that would be because it's right, RT-RT?
You didn't really need it, but
Oh,
if you
okay.
did it,
All
it's
right.
fine. So the lavage is first, with the brushing and washing second. So the 31624, and then the 31623 with a modifier 51, because it's a multiple procedure. And then what you're going to code is the fact that it was a neoplasm of unspecified behavior, and sometimes you might want to be aware that your third-party payers might want the washings separately, but in this case we're okay to code it the way we did.
what do you mean? Isn't that separate? Didn't we code it separate?
It became part of the brushing or protected brushing.
Struggle with that.
Well, your report says the area was brushed, washed, and then, to be more specific, so with
Right.
brushing or protected brushing. So what they're doing was they brushed it and washed it, and then to be more specific, it's more of a protective brushing, and then they went and did the lavage.
And how do you know that the lavage is
More extensive.
more extensive than the brushing and the washing? How
Because
would we
it's-
know that?
You wouldn't. You'd
So
have to
how would
ask.
we know which one would be first? I mean, when we're coding it, how would we know which one to code first?
Well, think about when you go to flush something out to get something off of a tube. Think of a tube, and you're trying to get this spot right in the middle of gunk, and you can't get it out, and you're sitting there with your hose sprayer from your sink, and you're trying to get it and get it and get it and get it, okay? So that's more extensive, more intensive. Whereas you just take a little bottle brush and you go in there and you, okay? So the lavage is more time intensive, more
So,
extensive.
next to lavage, we should write,
Time intensive. Because he even said, you know, they went down there because they saw something more. And they had to do a little suctioning to actually dislodge the mucus.
so if it says washing and brushing and it says lavage, then we know that we have to bill both separately, because they're not included one or the other.
Did you get that, Carolyn?
Yes.
Good.
What was the ICD-9?
Well, the ICD-9 is the neoplasm of uncertain behavior of the lung, so 235.7. Don't erase it. You can hate me later for it.
Tell me the lavage thing again.
Lavage is like,
No, just the
it's
little.
it's more extensive.
Thank you.
Have you ever, Lori, have you ever had your ears flushed out?
You said from the one.
You know how they
Is that what
get
you
wax out of your ears? And you go, oh, I got a whole bunch of wax, or I can't
No.
hear. And
No.
you sit on the table, and they get this gun thing, and they keep swishing water, and you get, is it like that? No?
Well,
Oh, that's what it feels like.
It could be like that.
Yeah, I think I had, it's probably old, because I've had a long time
That
ago.
was a long time ago.
Yeah, and then you get up, and you're all dizzy, and you're like, oh, that's worse than what it
Oh,
was
really?
before.
Yeah.
Okay, how do we get a malignant neoplasm out of this? Is a,
No, it's a uncertain behavior.
a neoplasm of
Oh,
uncertain-
that's where I did.
What's
That's,
the neoplasm?
I read it wrong. That's
They
why.
weren't sure if it was,
No cancer.
It says atypical cells cannot rule out malignancy.
right.
Well,
So when they say atypical, there's possibility that it could be a neoplasm of unspecified behavior. Anything atypical is unspecified
know.
behavior.
That's why I got it wrong.
So brushing's not included in lavage, code separately with modifier. With a modifier 50,
51.
51.
When you explained it like that, that was really clear. Because
Okay.
anything that's stuck and you keep like trying to wash out, takes time. And then like I'm probably, this is really kind of like,
I would think
I
brushing.
use my water bottles over because it's expensive.
Yep.
And what I do is I have a baby bottle brush.
Yep.
And you know, to just keep filling them is kind of gross because it gets that scum in there, and I go in there.
What kind do you have?
A Poland Springs.
You
water
can,
bottle.
oh, those water bottles.
Yeah, because
Okay.
I just don't like, you know, those are handy.
Yeah.
And then I buy another case and do it all over again. At the end, I don't have any, so I have to wait for the rest of the day and I fill them up again. You know.
so the fact that this person had a collapsed lung doesn't even figure into the diagnosis.
No.
You show up with a collapsed lung and nobody even pays any attention to it.
At this point in time, no. No, this is where we get into trouble because we think all of this extra stuff and we only need to focus on what's right in front of us.
Which was the post-operative diagnosis, correct?
Yes. Okay, let's try report 23, number 61. 223 in your workbook. Report 23, preoperative diagnosis, pleural fluid, unknown cause, postoperative diagnosis, loculated pleural effusion with removal of 40 cc's of bloody pleural fluid. Procedure performed, diagnostic thoracentesis. Where are we going to start? Thoracentesis. So go there and look it up. Tell me what you come up with.
Which report are you doing again?
23.
So he did a drain, he drained it, right?
Mm-hmm. So what'd you come up with for a code, Celeste?
I think it was 32556.
Close.
32557, because they used
Oh, they
imaging.
did. Oh, see, I didn't
No.
get it down far enough.
Lori?
No, 32555.
Close. Bonnie?
I have 32554.
32554.
That was right?
Yep.
Oh, all right then. Did they say?
Oh yeah, these give the answer, these ones.
Oh.
It's like Larry had checked.
I guess the reason why I thought it was the 556, or I thought they used guidance for one thing.
No.
I guess
Well, I was
guess
thinking they
didn't.
drained it.
And I thought they
Yeah.
drained it too, so that's why I.
2554 says aspiration of the pleural space.
But where did they?
That's draining, correct? Isn't it? Or am I wrong? Aspiration is pulling out.
Yeah, aspiration can be pulling out. Yeah. It says
Attempting to draw out fluid.
Aspirate is to enter it, isn't it? Isn't it to? It's not really to drain
Okay,
it.
where did they get?
They had to do 4 different sticks to get 40 cc's of fluid. There were 4 different pockets that they entered just in one general area that was marked by ultrasound, not imaging guidance.
Okay.
So this, of course, was done after marking it with ultrasound, rubbing the area with swabs to sterilize the area, and then using 20 cc's of lidocaine for local anesthesia.
So they ultrasounded it before they did the.
Yes. With a one-pass maneuver, we were able to get into some fluid. At first, actually, we did not get any. They moved over about an inch, and then they were able to get 10 cc's, so on and so forth. They kept going.
Okay.
So they really didn't do a whole lot.
Okay. So the aspiration Is that going in or taking, aspirating in?
You're getting
isn't it?
stuck. You're getting stuck on the aspiration.
Yeah, but I just want to make
Because
sure.
thoracentesis, needle or catheter.
Aspiration is pulling out.
Right.
Fluid.
They were
Okay.
trying to pull out fluid.
Okay, all right, so a pleural drainage, isn't that taking fluid out too?
Of pleural space.
Oh, of the pleural
Space. They
space.
they
Okay,
were
pleural
talking
is
about the
space.
space, the
Okay.
plural
It says
space.
plural.
Up there,
Right.
are you looking at 32556?
Yeah, that's
I'm
why
not-
I wanted to
With
see.
insertion of indwelling catheter, which it said
But-
it didn't do because.
Right.
They didn't, right.
Yeah, that's the
I-
difference right there.
Right,
indwelling.
that's what it was. Okay.
So Lori, the only difference you had was the fact that you
have
chose
to look
with
at
imaging
every
guidance.
single word.
And ultrasound is
Every
not
single
imaging
little
guidance.
Got it. Thank you.
When they talk imaging, it's more MRI or CAT scan.
Yeah,
Okay.
question on that.
Okay.
This is,
So you should have 32554 for that. And what would we look up for diagnosis? Postoperative diagnosis is a pleural effusion.
that's what you look up. Fusion.
Effusion, pleural effusion.
I think it's 511.9.
It is. Okay. So 5119 is the answer for the diagnosis code. 32554 is the procedure code. All right, let's turn to page 601 in your textbook and 181 in your CPT book. You'll see in 181, 182, and 183 they have diagrams for you for the cardiovascular system. I would know that you can go back to these sections. So you might want to put a tab up for, cardiovascular illustrations or whatever you want. Just know that this is where you're going to find these. So in the cardiovascular system, you're going to see that you might require codes from radiology, medicine, and surgery. So page 185 in your CPT book. What I would do right at the top of that page, 185, may require codes from radiology, medicine, and surgery. Now, with your radiology, it would be for diagnostic studies. With your medicine, it would be the non-surgical and percutaneous. With the surgery, it would be open and percutaneous. So that would be why you would need codes from these sections. If it was radiology, it would be for diagnostic studies. If it was from medicine, it would be for non-surgical and percutaneous. And if it is surgery, it would be open and percutaneous. So some of the terminology that you want to be aware of for cardiology, the first one would be invasive. When we think of invasive, we think of taking over. Well, in cardiology, it means enter body, entering the body. So for example, when we're opening the chest for removal of a tumor on the heart or a percutaneous placement of a catheter in an artery, this is what we mean by invasive. Invasive means entering the body. You will see that both your medicine and surgery sections contain invasive procedures. Your non-invasive procedures are that which do not break the skin. So for example, electrocardiogram. All right, the codes for the procedures in the surgery section. We're going to start with the heart and the pericardium on page 185 in your CPT book. These are codes 33010 through 33999. Underneath the heart and the pericardium, you will find pacemakers and valve disorders. Pay attention to your parenthetical notes that say for radiological supervision and interpretation use, and it indicates what code you should be using. It also, you'll see primary procedure, or for open pericardial biopsy, use code, and it lists the code. Your arteries and veins, 34001 through 37799. You're going to see that they're both percutaneous and open procedures. You're going to see a lot of extensive notes throughout. You will see frequent changes with the medical advances. Look at some of the subheadings underneath heart and pericardium. You have pericardium. You have cardiac tumor, pacemaker or cardioverter defibrillator, the pericardiocentesis. This is percutaneous withdrawal of fluid from the pericardial space. Let me find that in here.
The first one, 33010.
Say that again.
33010. The first one under heart.
Pericardiocentesis. You want to write beside that percutaneous withdrawal of fluid from pericardial space. 33010.
What are we writing?
Percutaneous withdrawal of fluid from pericardial space. Percutaneous withdrawal of fluid from pericardial space. 33010. Percutaneous withdrawal of fluid from pericardial space. Excision of cardiac tumor, 33120. Open surgical procedure for removal of tumor on heart, simply removal of tumor on heart. Three, 33120, removal of tumor on heart.
33120, is that what you said?
Mm-hmm.
And removal of tumor from heart.
Yes. The pacemaker or pacing cardioverter defibrillator. These are devices that assist the heart in electrical function.
Now? Sorry. 331.
The pacemaker or pacing cardioverter defibrillator. Devices that assist the heart in electrical function. And then you have a bunch of notes to read. Turn the page to 186 in your CPT book.
Device that assists the heart.
In electrical function. Three 33202 through 33249. You're going to see over on page 186 in the right-hand column down near the bottom, it tells you what a single lead, a dual lead, and a multiple lead are. You want to know what those are. Throughout these codes, they are going to be divided by where the electrodes or the leads are placed. What is the approach, and what is the type of service. So your codes 33202 through 33249, what you want to know is where are the leads placed,
And the approach.
what's the approach, and what's the type of service. So where are the leads placed, what's the approach, and what's the type of service. Keep in mind that pacemakers can be temporary or permanent.
And that's through 33210.
33202, 3324.
I thought it was 33209.
332. 33202 through 33249.
Oh, thank you.
That wouldn't have been bad.
This is the area my daughter's in, this cardio. She's showing me all the math stuff she had to do the other day. She'd look at all these like 6 or 7 things. She had to take all, like, say this says 32 and this says high 20. She had to take all this and come up with a formula to be able to know how much of each medicine she had to give because of all that.
Yeah. So now, where are the leads placed? So let's talk about that. Where are the leads placed? You actually have a figure in your textbook that shows you, let me see, figure 21.6. 21.6 shows you left ventricular pacing. Figure 21.6, left ventricular pacing. Next page, Nancy. Right there. All right, so when we place the leads, we're either going to place it on the atrium, which is the single chamber, which uses only one lead, or a ventricle, which is a single chamber, or both. We might do a dual chamber, which uses 2 leads. So again, single lead, dual lead, multiple lead, the definition is right there on page 186 in your CPT book. If you did a biventricular, it would be both ventricles and right atrium, which would be 3 leads. And it's going to be in the notes. All right, it will tell you in the operative reports, in the notes, all of that stuff. So where did we place them? We just talked about where did we place them. Now, what is the approach? What kind of approach do we have? We have epicardial or transvenous. Epicardial is an open approach to place it right on the heart. A transvenous is through the vein to place it into the heart.
Now that's for the leads, right? To place the leads. So the actual thing has to be planted under the surface. That has to be cut and
They place it in a pocket of skin.
Epicardial
It is open procedure to place it on the heart. A transvenous is through a vein to place it in the heart.
and
Transvenous is through a vein. Okay, then we have a type of service. Is it the initial placement or is it a replacement of all or part? So the type of service, is it an initial placement or replacement of all or part? I'm going to tell you that when you're doing the exercises for these, be very careful about the wording, because it will say removal of pacing cardioverter defibrillator pulse generator only. It's only the generator. Just be careful when you're reading your exercises and you're reading the code descriptor.
So the type of service is replacement, what else was it?
Initial
Repair?
placement,
Okay.
initial placement, or replacement of all or part, and the number of leads that are placed.
little map, I mean, this is kind of almost like a little cheat sheet.
Yeah. So, with the pacemakers and the pacing cardioverter defibrillators, your patient record will indicate whether it's a revision or a replacement. So be aware of that. Usual follow-up period is a 90-day global period. So usual follow-up period is a 90-day global period. And the use of a 78 modifier indicates that they're returning to the operating room within the global period. All right, 191 in your CPT book, electrophysiologic operative procedures. In your textbook, it's going to be under the same heading, electrophysiologic operative procedures. These are codes 33250 through 33266. This is where the surgeon repairs the defect causing abnormal rhythm. So the surgeon goes in and repairs, and it tells you right there in the first line, the family of codes describes the surgical treatment of supraventricular dysrhythmias. It gives you definitions of limited and extensive. This is usually an endoscopy procedure. These codes are based on the reason for the procedure and the approach. And whether or not a cardiopulmonary bypass was used. Underneath incision, this is where the chest is open to full view. So your 33250, operative ablation of supraventricular arrhythmogenic focus or pathway without cardiopulmonary bypass. And then the next, yes, chest is open to full view.
Cracked it. Use the spreader.
Can't be thinking about it. It was like John.
Yeah, that hurts.
He still can't drive.
Yeah.
6 to 8 weeks without
Yeah.
driving, because if he
That
hits
hurts.
it,
Mm-hmm.
Patient activated event recorder. Next page, 192 in your CPT book. This is also known as a cardiac event recorder or a loop recorder. Also known as cardiac event recorder or loop recorder.
Can you find that on the loop in the back?
I don't know. This is usually an internal surgical implantation that's required, and it is divided based on the device being implanted or removed.
Doreen,
Yes.
I don't know if it was at the end of the chapter, the questions or anything, but it had to do with the loop recorder. That threw me for a loop. It took me
Okay.
forever, but I finally figured it out, and when I did, it was simple.
Where'd you find it?
It was a couple, I went back and forth on different codes, and I just didn't read down far enough, and you have to read down far enough through the codes.
Yep. It will get us every single time. It still gets me too. Okay. Cardiac valves on second column on page 192. These are divided on the valve and the cardiopulmonary bypass. So 192 in your CPT book, right-hand column, cardiac valves 33361 through 33478. Divided on valve and cardiopulmonary bypass. Is it aortic? Is it mitral? Is it tricuspid or pulmonary? Those are the words you should highlight in those codes. Aortic, mitral, tricuspid, or pulmonary. And you'll see
33361?
33361 through 33478. And if you look through cardiac valves, you'll see the first subsection is aortic valve. You'll see if you turn the page, the next one is mitral valve, the next tricuspid valve, and the next pulmonary
So
valve.
they have their own section.
They do.
Okay.
Then you have the transcatheter aortic valve replacement, which is a TAVR, and an implant, which is a TAVI, that falls all underneath the cardiac valves. It is your codes 33361 through 33369, 33361 through 33369. These are done via artery. Is it percutaneous, open, or transaortic?
I have a question about arteries.
I'll try.
I keep seeing this expression, native artery. And it's also, what is it? What is a native artery?
It's your own artery.
They can do like a graph from your own arteries, they pull it from.
But it's not usually with graphs. It says, apparently you have when you look at arteriosclerosis, it says native artery, and sometimes it's under extremity native artery.
Because you have the artery.
It is your own. And so they're taught, what that means is it's not a synthetic one.
Right. Yeah, native artery is your own.
Okay, so I'm lost on the TAVR and TAV. So the codes
33361 through 33369. You want to know if it's via artery and is it percutaneous, open, or transaortic. So look for those words in those codes: percutaneous, open, or transaortic.
percutaneous.
Open or transaortic. Transaortic.
Okay.
The codes are divided based on approach. And keep in mind, your add-on codes are the ones that have the plus signs on them. They are going to be in addition to the more primary procedure.
They're first and then the primary second, right?
No,
The
the
add-on
add-on codes are always second.
Okay.
Anything
all right.
with a plus sign is
second.
always
Okay.
second.
All right. So it was approach to find those?
Yeah.
Okay.
The coronary artery bypass graft, or also known as cabbage, is performed for what? Why is that performed, Bonnie?
For cardiac insufficiency, blocked atherosclerosis.
Right. So if you look at figure 21-8 in your textbook, underneath coronary artery bypass, it has a picture there of some atherosclerotic vessel. Show that to your loved ones. Then if you look at figure 21-9, that's a coronary artery bypass. You need to determine what was used in the repair. Was it a vein? Was it an artery? Or was it both a vein and an artery? So codes 33510 through 33516 indicate it was a vein that was used.
Used for
Bypass.
to put in between So they can put a piece of vein in between two pieces of artery.
Yeah.
Okay.
If they determine it will work.
Was it a vein or an artery?
Artery would be 33533 through 33548. So you want to determine what is used in the repair. Is it a vein, an artery, or both?
Isn't that amazing how they do that now? They just bypass that.
Yeah.
See, my father had a 6 bypass.
But they can, apparently, they let them, keeps them from getting clogged up.
No, you can do it after, they say in 10 years, or maybe less.
Yeah.
I mean, depending on how bad or if it's genetic.
And I guess balloons can clog up, and everything, the stent that they put in there, you can also
Yeah, it
manage
can
to
go,
clog
it can
up.
go back again if you don't, I mean, sometimes it's just genetics, you just can't help it, even though you eat good and exercise and stuff. But, my father said they took so many veins out of his legs because he had a 6, that his legs are actually weak. He doesn't have the strength that he used to because the blood flow's not going through.
Yeah, he's not getting the nutrients in his
so
legs that he
I mean,
needs.
Why didn't they use something synthetic, can't they?
I don't know if that's.
They try not to unless they
Yeah,
absolutely
just
have
tried
to.
take everything from his body.
'Cause
So, I mean, he still keeps plugging and walking. He said they hurt at the end when he does this 1.5 miles.
The coronary artery bypass, you also want to pay attention to the number of bypass grafts that are performed and if they use a vein or if they use the arterial grafts. So if we have 3 venous grafts, okay, then where would you find that? Under what section?
Under the venous grafting.
Right.
So one thing I figured out when doing this, you add on codes, like the combined venous coronary bypass, arterial venous. So I had to get my primary one either from the arterial or the venous, and then the secondary comes from the combined, right? Okay.
Yeah.
With a modifier, no, we don't use a modifier
No,
on the
not
secondary.
necessarily.
Okay.
No.
Yeah, no
51 modifier. All right.
So,
Arterial grafting, 33533 through 33548, 197 in your CPT book. These are divided based on the number of grafts. And is it a right coronary artery or an RAC? Or is it a left main coronary artery, LMCA?
Okay, I'm lost. Where are we?
Page 197 in your CPT book.
Yeah?
There'll be the arterial grafting codes 33533 through
Okay.
33548. These are divided based on the number of grafts.
Oh, yeah. What was this? Right.
What did you say, M? What were the initials?
RCA is the right coronary artery. LMCA is the left main coronary artery. You know the appendix you have in the back of the book about vascular family tree?
Appendix L?
Yes, Appendix L. You want to pay attention to that when you need it to use to do these exercises. On page 197 in your CPT book, you'll see 33542, 33545, and 33548. These are for myocardial resection, repair of a ventricular septal defect, and a ventricular restoration procedure. Page 197 in your CPT book, code 33542, 33545, and 33548. Resection, repair, and restoration.
Speaking of appendices, is there any place in this book that has an entire list of all the codes and the pages they are on? Because I noticed when I got into the radiology and the medicine, you'd be going along in numerical order, and then it would just disappear and turn up 2 pages away.
No,
Crazy man.
it just means that they resequence the codes.
Right, and in one of the resequencing, it said, see this numeric to this, and it wasn't in there.
Right.
It was in some other page.
Right.
I mean, I could get if they resequence it, if they tell you where to put it and they tell you the
No.
right place.
No. No. Okay. Combined arterial and venous grafting. We kind of already went over that, 33517 through 33523 on page 196. Let's turn to page 201 in your CPT book. Endovascular repair of descending thoracic aorta, 33880 through 33891. You will see here that there is, these are procedures to report placement of an endovascular graft for the repair of the descending thoracic aorta.
What code are you on?
33880 through 33891, page 201 in your CPT book. So first sentence, these represent a family of procedures to report placement of an endovascular graft for repair of the descending thoracic aorta. This is where you'll see synthetic aortic prosthesis placed via a catheter. This is usually less invasive than chest or abdominal incision. And this will include the diagnostic imaging pre and intraoperative. Over to page 205 in your CPT book. 34001 through 37799. This is the embolectomy and thrombectomy, arteries and veins. These codes are only for the non-coronary vessels. These are going to be divided based on whether it's an artery or a vein that is used. So right underneath arteries and veins, primary vascular procedure listings include establishing both inflow and outflow by whatever procedures necessary. Also included is that portion of the operative arteriogram performed by the surgeon as indicated. And it goes on to tell you that for unlisted vascular procedure, use 37799. So what you want to look at when you're looking at these codes for 34001 through 37799 is it an artery or is it a vein? And you're going to see that there are different codes for embolectomy, depending on if it is an artery or a vein. So page 205 in your CPT book. Artery and vein subheading, code 34001 through 37799. So, is it an embolectomy? Is it a thrombectomy?
Embo would be in the arteries, or the.
Is the embolectomy depending on an artery or a vein?
Okay, so it could be either one.
Yes, but
Okay.
you want to know,
Right,
does it say artery or does it say vein?
okay.
I'm confused about, an embolism is a traveling thrombus, is that,
Yes,
I have that right?
yes.
And a thrombus is a blood clot, so a blood clot that has moved from someplace else is an embolism?
Mm-hmm.
Wish they call everything by one word.
That'd be too easy.
I don't know who came up with this. Don't
That's
shoot
how
the
my husband's
messenger.
mother died. Well, in the brain.
Right?
Blood clot in the
What?
brain. That's how my husband's mother
The
died,
vocabulary.
when he was like 17. I found
Yeah. All right, so catheters are usually placed into vessels for monitoring, removal, or repair. Just a point of information. Catheters are placed into the vessels for monitoring, removal, or repair. And you have figure 21.14 in your textbook. They show you catheters for arterial cannulation.
Is there some place we should write that in here?
No.
Okay.
When we talk about non-selective and selective, let me take a look here. They should have that as a definition.
On page 615.
No, in your CPT book. All right, on page 216 in your CPT book, they talk about selective vascular catheterization. So selective is placement of the catheter into the second order of the venous system. So look at 36012 on page 216 in your CPT book. That is an example of a selective. 36012, page 216 in your CPT book. That's example of a catheter placement for selective. If you look at code 36000 on the left-hand column, that is an example of a non-selective catheter placement because they're introducing it into the vein.
Which one?
36000.
Oh, that's just a placing of the catheter. I mean,
Non-selective, yep.
And 002 is selective.
012.
012, thank you.
Yep. All right, so I just want you to sit back and think for a moment and listen to what I'm saying. Your vascular families are going to be like a tree. The main branch is the first order. It's your tree trunk. So this is where appendix L comes in, okay? The second order of the branch is the tree limb. The third order branch is the tree branch. Okay? So first order is the tree trunk. Second order is the tree limb. Third order is the tree branch. Appendix L, you should tab it because this tells you your vascular families. You're always going to list first, second, third, and beyond third order branches. You assume that your starting point is always the catheterization of the aorta. We're going to code to the furthest extent. Just like we talked about earlier doing an endoscopy, we were coding to the furthest extent, even though we went in through the mouth and we ended up at the endobronchial whatever. When we do a cardiovascular whatever, it's the farthest extent. Keep that in mind, the farthest extent.
One code?
It
You're
could.
not gonna have a code for the trunk and the
You're
trunk
not
and
going to
the
have a
trunk.
code for each order, no. You just need to know, okay, I started in the A order, but guess what? I ended out here on some third order branch. That's your code. Not that you started at the A order, but that you ended up on the third order branch or the fourth order branch. Wherever you ended up in your cardiovascular tree is the code that becomes your primary.
And those are for the intra-arterial, the intravenous.
Yep. So figure 21-15 in your textbook talks about the brachiocephalic vascular family, and it shows you first order, second order, third order, fourth order.
Page you on?
In your textbook 615. Let's go back just a little bit to 34501 in your CPT book, 34501. All right, over on page 205 in your CPT book, we're talking about venous reconstruction. The types of repair here that you see in these 5 codes: valve of a femoral vein, a vena cava, and the saphenopopliteal vein anastomosis. Spell that 10 times fast.
So like an IV start, like a 36,000 would be the further, that would be, you wouldn't want to code that if you can code something more specific.
Right. You're always coding to the highest level of specificity.
So like when you do IVs, for instance, we don't bill an IV start if we bill an IV push.
Right, but what does that have to do with the venous reconstruction?
I'm just trying to get it straight in my mind how you do, in what order you do it in, I guess. I don't know.
Okay. Well, an IV push for hydration is what you're talking about?
An IV push for medication.
Okay.
Or, yeah, hydration.
Doesn't have anything
Okay.
to do with this.
I'm just, the IV start would be your furthest would be the one that you code last, or this, in this case, the 36,000 would be the one you code. If you have something more specific, you would code that first.
Yes.
Okay.
All right. We all know what an aneurysm is that correct?
Mm-hmm.
An aneurysm is a ballooned or weakened area of a vessel, okay? On page 206 in your CPT book, endovascular repair of the abdominal aortic aneurysm. This is actually something that they monitor and watch. They don't necessarily go in and repair it as soon as they find it. These are codes 34800 through 34834. You're going to see a lot of extensive codes preceding that you really should be reading. This uses fluoroscopic guidance. So to report that, you would use some radiology codes. Pay attention to your parenthetical notes. This also includes access, catheter manipulation, balloon angioplasty, stent placement, and site closure. All right, so when you're looking at these codes, pay attention to what are they using. Okay, 34804 is using a unibody bifurcated prosthesis. And 34805 is using an aorto unilac or aorto unifemoral prosthesis. So we're going to have to pay attention to our notes and query the provider. Page 208. 208 in your CPT book, code 34900. It's one simple code, but look at the write-up before it. This uses fluoroscopic guidance, and the code for that would be 75954. So right underneath 34900, you can say fluoroscopic guidance 75954.
What's the code again?
75954.
That's really true about that aorta. My that's my husband's uncle actually. They probably monitored him for a year.
Yeah.
And he said, okay, it's time to go.
Yeah. Page 209, CPT book, repair of the arteriovenous fistula. This is 35180 through 35190. This is an abnormal passage, and it is divided based on the fistula type. So you're going to highlight or underline congenital, acquired and traumatic, or by site. So it's going to be divided by type. Over on page 211 in your CPT book, angioplasty, 35450 through 35476. This is going to be open or percutaneous. So open or percutaneous. And when they talk about a transluminal angioplasty, on code 35450, this is where a catheter is passed into the vessel and stretched. And if you look at these, you're actually going to code per the vessel. Your stent placement is reported separately, and the code imaging is separate. And it tells you right in the parenthetical notes if you're going to use imaging to use a certain code. Over on the right of page 211 in your CPT book, your non-coronary bypass grafts, these are codes 35500 through 35671. These are divided by vein, in situ vein, or other than vein.
What about bypass grafting?
Right, it's bypass grafting, and the codes are 35500 through 35671. Page 211, right-hand column.
Okay. That's not a part. Okay, sorry.
That's okay. Bypass graft, and then it's vein, and it's procurement of the saphenous vein graft is included in the description of the work for 35501 through 35587.
Thank you.
Mm-hmm.
So the 35500 is an add-on code?
Yes, it is. And it tells you in parenthetical notes to use it in conjunction with, and it tells you what codes you can use it with. Over on page 216 in your CPT book, we have vascular injection procedures. These are codes 36000 through 36522. So page 216 in your CPT book, vascular injection procedures, 36000 through 36522. These are divided into intravenous, intra-arterial, intra-aortic, and venous. And you have a lot of notes to read here as well. You'll see right there in some of the subheadings, it says intravenous, it says intra-arterial and intra-aortic. And over on the next 221, it has the venous section. So the vascular injection procedure codes are page 216 to 221. What you're going to find with these codes is that they're used for many procedures, and they will include local anesthesia, right there on page 216 in the first paragraph. Listed services for injection procedures include necessary local anesthesia, introduction of needles or catheter, injection of contrast material with or without automatic power injection, and or necessary pre- and post-injection care specifically related to the injection procedure. So that whole first paragraph is worth highlighting or underlining. Over on page 230 in your CPT book, transcatheter procedures. Arterial mechanical thrombectomy is code 37184 through 37186. This is removal of the arterial thrombus by a mechanical device. It should tell you that right there in the paragraph. Again, there's a lot of notes here. With the arterial mechanical thrombectomy, this is used to report a variety of the transcatheter procedures. With the venous mechanical thrombectomy, the right-hand column on the bottom, 37187 through 37188. The venous mechanical thrombectomy, this is the removal of the venous thrombus by means of a mechanical device. Okay. So keep in mind with the cardiovascular, it's also in the medicine section. And in the medicine section, it can be non-invasive or invasive, and it can be diagnostic or therapeutic. So if we were to go to the medicine section, and you look at cardiography, cardiovascular monitoring services, cardiovascular, page 518 in your CPT book. You'll see that for cardiovascular in the medicine section, they're either going to be invasive or non-invasive, diagnostic or therapeutic. And if you turn to page 545 in the medicine section in your CPT book, it goes right into the subheadings of coronary therapeutic services and procedures. It goes over and you have on page 546 a whole bunch of notes there. Over on 548 we have cardiography. This is appropriate when an order for the test is triggered by an event. 549, cardiovascular monitoring services. 550, implantable and wearable cardiac device evaluations. You also have echocardiography on page 554. So keeping in mind that we have some cardiac stuff also happening in the medicine section as well as radiography. So over on page 557 we have cardiac catheterization. We also end up having some therapeutic services that end up being codes 92920 through 92998.
And 92920
Yes.
is one of the uncoded ones,
Yes.
unsequenced.
Right.
And it's like, it says see those ones where it says to see what numbers. It's not within those numbers. It's on the next 2 pages.
Right.
But they don't tell you what page
No.
when it's out of, it's like,
No, they won't.
But it's bad enough they're telling you to go to the wrong place, they don't tell you the page either.
Yeah.
I don't get it. I mean, I kind of was paging around in frustration when I caught the number I wanted.
Mm-hmm.
I don't know if that'll work every time.
So let's go to the 92920, page 544. And what note I want you to make at the bottom of this section, underneath therapeutic services and procedures, these are going to be groups that are divided by method, location, and number.
I'm sorry, which one?
Page 544,
Yeah,
right-hand column, underneath the cardiovascular,
yeah.
right at the bottom on where you have blank
Okay,
space.
thank you.
These codes are going to be divided by method, location, and number. So when I talk about method, is it a balloon or is it a blade?
Method, location, or
Number. When I talk about location, is it aortic or mitral valve? And when I talk about number, is it single or additional vessels?
when you talk about number one, sorry.
Vessels. All right. How's your head?
Spinning.
You had, now, in that medicine section, there's non-invasive, but is there some invasive stuff too?
Not in the medicine
Not in the
section.
medicine, okay.
It's going to be in the surgery
Okay.
section.
They were.
No, I can send you the answers if you did it.
Yeah.
Okay. So for next week, it's 22 and 23, which is hemic, lymphatic, mediastinum, and diaphragm, and digestive system. I will get the answers out for chapter 21. You need 22 as well?
I just need two.
Yeah, which,
Send answers for 21?
Oh, and, yeah, 21.
Okay.
And I guess those other answers that
The one that you no one
were
got.
sent,
Because I didn't.
I can resend them.
thank you very much.
And do you want us to do the even problems or do them all?
I would like you to do at least the even.
Do the evens,
Okay? And no, I don't have these exams ready. I'll have them ready tomorrow. All right, Carolyn.
Bye.
okay. Hi.